to start off with some questions, and while the people here in the audience think of some questions, what I was most impressed with was how kind of clinically grounded and problem grounded the models that you guys are working on are. And I find like a lot of times people develop models and they don't necessarily have that. So can you talk a little bit about how you kind of have that inspiration to make and keep that grounding in your work?
Well, I think interdisciplinary collaboration is a key, right? You have to work not on your own or as a data scientist, but you have to collaborate with clinicians and they tell you what the actual needs are. For me, it was very important.
And I think it also relates to what I talked about, this intersection of spheres, right? We might have methodologies available to us that we can tackle from an AI perspective, but it doesn't mean that they're relevant to clinical questions. And I think just understanding where these two spheres meet is so important.
I think the most important words came from you, because you said we won't deliver an AI model if it has no clinical or scientific benefit. And I think that's the most important point. So everything starts with a challenge or a problem where you have to find a solution for.
As a follow-up, I think we all want to believe that our models are 100% perfect and correct all the time, but they're not. So how do you think the impact of wrong predictions results in users and impacts what you do and what other people do?
Well, from this point of view, I must say that my results are showing also with the colonoscopies that actually medical doctors, so the final decision makers, are quite robust against bad advices. So maybe this is not entirely clear now, but human mind is good in spotting when something fishy does not fit into reality. And if I may say, that's a good direction in which to work with. So in a way, in the future, probably AI will enter the daily life more and more. And what we have to develop is what we call for humans a theory of mind. So people are intuitively have an idea of how the mind of other people work. And in the future, we will need to develop something similar for machines. So we need to have an intuition of how different types of machine work and how these different types of machine can fail, so that we reach a final decision that will be the best for the interest, in this case, of the patient.
And I just want to add on, one of the things we have to do as AI models are more and more integrated into clinical care is to train our clinicians. A lot of them are still stuck on this mindset that computer knows best, because they're used to these models that are hard-coded, that always gives you the same answer every time you ask the same question. But things are changing with generative AI, and it's embedded in a lot of the workflows that it's going to be in the future. So they need to understand that the clinicians need to understand to really think use their critical thinking and really evaluate and investigate the outcomes that these generative models that provide to you. So I think it's going to begin with a lot of clinician education and a mind shift, working with models instead of believing everything that they say.
But it will be interesting to see what happens when it comes to a legal case. That if a patient gets harmed and you get a legal case out of that, it will be interesting to see how the judges decide on that. Yeah. And who's responsible? If it's the physician, what probably will be the case, or if it's the one developing the model or deploying the model or whatever.
Yeah. I think a follow-up to what Dr. Hamilton was saying is that, right now, our current generation, they're not as used to the AI and technology, but as newer generations where everybody gets ChatGPT, becomes more familiar with it, how do you think the landscape and acceptance and also how they interpret those AI models is going to change?
I think one of the things that's going to change is that I'm going to predict the generation that will drive AI is going to be the Gen Z and the younger millennials, because they're used to, they live in this frictionless world. They use technology for everything. And when they come to your offices, your clinics, they have more information than you at their fingertips. Sometimes I have seen patients come in with the GPT summarized medical records that they bring to you. So I think those guys are going to change the landscape. And it's the same for physicians and nurses entering the workforce. And they go to a workplace and they are flabbergasted by these old archaic systems. We're still using Excel spreadsheets and fax machines. So I think those are the generations that are really truly going to drive AI and AI models, because they really are used to a world that is filled with technology.
Dr. Reverberi, did you want to also contribute?
Yeah, if you want. I mean, I can raise a question here. One of the things that often goes around in this AI domain, one of the fears is that there might be a chance of this killing. So for example, people starting to rely more and more on AI tools. And then suddenly, the training changes in some ways. And at the end of the day, you are no longer able to do something that now the AI does, and you delegate fully to the AI, losing your ability of doing that. And this is in principle a possibility. I'm not that scared that much toward that, but it would be interesting to understand how medical schools and the day-to-day job will change in the future, in order for sure to prevent an outcome like this one that you don't want. So you really fully agree with the fact that the medical doctor needs always to be able to critically evaluate any types of outcomes. But on the other hand, also I have the freedom of, understanding when he can rely on an output of the machine that in some situation might even be better compared to his or raw intuition. And so it's a fine tuning here that I guess will impact medical schools in the future, but not only medical schools. Also I'm a university teacher, so I see very well that this will change a lot also, our work. So I'm very curious.
But may I add here, I think we already have a perfect blueprint for this in our society. And if you think about it, we teach children in school calculus and algebra and all these things and how to do these calculations by hand. But we have all the tools available, the calculators, the computers can do all these calculations in theory. Yep. Nevertheless, before we hand them the calculator, we teach them how to do it by hand. And I think the same principles apply here. It's really, we can take this as a blueprint. And
So I want to point out again that Dr. Hofmann, you talked about, we don't need the clinician coder. So I wonder if from the panelist side, where do we see the integration of clinicians into the data science field?
Say it again, please.
You talked about how we don't really need the clinician coder now because a lot of coding can be done with LLMs. But then what is the role of the clinician?
Well, maybe I need to elaborate more on this. So the clinician coder I'm referring to is someone who is an expert in both domains. And I think this is just, as I said, it's unrealistic on a larger scale. There may be some individuals that are really, really good at two things. But again, this cannot be the goal as a society to develop an armada of clinician coders. Apart from this, what I referred to regarding coding is very specific about coding, the skill of hacking into your keyboard and writing a script that makes the computer do something. Still, as I said, there is a big role for the clinician being involved in data science, methodology-driven research. And this obviously requires clinicians also to get familiar with very basic, fundamental principles of the field and just gain a solid understanding of what can be done, how can it be achieved, and then being able to communicate with the data scientist, the AI researcher, to really make it happen.
Anyone else want to add that?
Yeah, I'm not so sure how much vibe coding will bring us. So you see this especially in the digital world, that a lot of the code written by vibe coders has a lot of critical errors regarding security, regarding leaked ChatGPT keys, because they put it on GitHub without knowing what a key is. So I'm not so sure. Of course, the code written by the large language models is great, but you still need to read it line by line to check for errors. And if you can't code and do not know what those lines mean, you will never master this. So this will facilitate our work, but I don't think it will take away the work.
Well, I think,
No, please go ahead.
I was just going to say, I think the future of healthcare, when we look at that, it's going to be one of augmentation, not full automation. But as technology advances, those lines are going to blur. We're going to see AI involved in maybe diagnostics more, surgeries, and things like that. So it's very important, I think, the physicians and nurses to educate themselves, however they can. Whether they want to take coding, they want to go into the field of informatics, whether they want to learn how to do research and AI, prompt engineering, all of those things I think going to come in very handy because the future is going to belong to them.
I mean, I was just going to say, I also think at least basic coding knowledge is very important. Not that you have to do it on a daily basis, but you have to be aware what is possible because it opens your mind to these things. You work and think differently if you know what you can do if you can code.
I'll take any audience questions.
I'll make a quick comment. It's not a question. I think as I was listening to this, it reminds me, the thought that keeps going through my mind is whether, going back to the old expression of to code or not to code. I think that's really what you were talking about. And I think it will be very interesting to see what happens, because I do think 25 years ago, when SAS Enterprise Guide and some of these other things came to be, I certainly thought nobody would code. And it would be interesting to see what happens, because nowadays I do think still a lot of people code and they enjoy doing it. But I do think the prompt engineering is certainly something that will be happening a lot too. So, and of course, I do want to thank you, but I'll do that at the end. I think it was a wonderful discussion. Thank you.
I will also disclose I have a mechanical keyboard myself at home, and it's love the class. Any other questions? Oh, Dr. Canago.
Well, thank you so much. So I greatly enjoyed this session, but I have a very specific question for Carlo. I find this concept of metacognitive awareness very interesting.
Yeah.
And I'm really wondering, are there ways to teach this characteristic? Because if I understood you correctly, being aware of one's own ignorance is a great benefit to really improve. Now, I was really wondering, are there any psychological strategies, means to teach kids, students, adults, this characteristic?
So, I mean, it's very hard. Actually, is a phenomenon that is very common. Also in medical domain, there are classical studies from the 70s. And a funny one that I always teach to my students is that, so I don't remember what kind of measurement. It was a noisy measurement that had to be taken in the cardiology domain. I don't remember the name. So they asked several medical doctors to give an estimate of this heart pressure. I don't remember what was the thing. So they asked to senior and young doctors to do this kind of estimate based on the clinical assessment of a patient. And then they asked about the confidence. And the funny thing, since the measurement was really noisy, I mean, the accuracy was bad, but what they noticed is that with experience, the confidence was rising while the accuracy was remaining the same. So there is this part in which you see how difficult, how common is overconfidence and how this can take over. And the general advice that is given in order to try to constrain a little bit this phenomenon is, and this is an organizational issue, to provide feedback, a lot of feedback whenever you can. So in many, many situations, clinicians, they take decisions and basically they cannot access in an easy way the end result of each and every of their decision. There is a lot of shortage of time, and so they don't go back usually to look at the past decision that they taken, whether they were good or not. And so if an organization provide each and every person to a regular and unambiguous feedback about their decision, day by day decision, this is a huge improvement in at least understanding that maybe sometimes they were overestimating how sure they were about the decision. And remember, I mean, another powerful thing is maybe you know about the hindsight bias, no? Things that like when you know that something is right, you tend to say, I knew it, no? And actually, if you ask before you tell what is the right thing, well, then it turns out that it is not really true that you knew it, no? So it's, in order to organize a proper feedback, you need to keep track of the decision when they happen and how sure is the medical doctor about the decision when they happen, and then to give feedback afterwards, so he might start to realize, okay, I was very sure at that moment that it turned out that this was wrong, or the other way around, I wasn't sure it was correct. And this start to help people calibrate, so calibrate their feelings of being, their confidence with reality, which is a really precious tool for change, I would say. It's just the start, and then say, I mean, realizing that that can be improved, and then finding the tools to improve, like you did. I mean, you did exactly this thing, finding problems, and then that's the start, knowing that there is a problem there, and then finding the tools to solve it. That's a great thing, but knowing that there is a problem, it's not obvious, and that's definitely the thing.
I think we have time for one more question.
Yes, thank you. Congratulations to the 5 speakers. Excellent presentations. My question is to Dr. Reverberi, again. I'm very curious, and your presentation was very interesting. And I also understand that in general, humans are overly confident of their decisions. My question is, in your research, have you done analysis in subgroups, meaning between age group, like you could think that the older you are, the more confident you could get. That's a guess. And also between male and female, I would be very curious to see who is more overly confident to make those decisions when they are facing that another person probably has more experience, right? So I would be very curious about that. Have you done those analyses?
Controversial question. Careful how you answer.
Unfortunately, I didn't. So there is. The thing is, there is a lot of individual variability, and I witnessed this also in my research. So there are people that are calibrated, and there are people that are far away from calibration. One of the main things that has been published in literature is the relation of your level of calibration with your basic skill in that problem, okay? So that's it's called Dunning-Kruger effect. So the worse you are in solving a problem, the worse you are in understanding that you are not good in solving that problem, okay? Of course, this is a problem. And at the end of the day, the thing that works better in order to improve this level of calibration is improving the basic task ability, because you get, while you understand better the basic task, you also get a better feeling on how good you are in doing that. So that's one thing of inter-individual variability. For the other, actually, I am doing some ongoing research exactly on that. So the variability, gender variability, and other inter-individual variables that might predict that, and I'm pretty sure is gonna be the case. Well, of course, typically the males are a little bit more overconfident. That's a known phenomenon. If you wanted to know that, it's not my research.
We have 1 minute left. I do want to thank the panel and just give an opportunity. I think our sample, we're a little bit of sample bias, and we're probably leaning towards the all-in for AI. But what would you say to the AI skeptic as parting words for this?
AI skeptic?
Yeah, people who aren't into it.
I would say that if, we were talking last night about the number of nephrologists going down, decreasing, and the similar is true in nursing. State boards of nursing in the United States, they predict that one-fifth of the nursing workforce is going to either retire or quit because of burdens and stresses of their job by 2025. 2027. That's 2 years from now, 1/5 of the nursing workforce. So if we can give these doctors and nurses better tools, lift their administrative burdens, perhaps they'll say, okay, that's not so bad. I'll stay on another few years. So then we can bring some others in the pipeline. I think that's how AI is going to help us solve some of the staffing shortages in the future. I think we have to be all in.
All right. If nothing else, then we will end the session. And thank you so much.